Hello everyone, I'm Megan Martin and I'll be discussing the health belief model. Before we dive into the history and constructs of the theory, I want to give you some information about what exactly the health belief model is. The health belief model is an individual level theory, meaning it focuses on the individual as the primary source of behavior and it doesn't look to outside sources like the environment. It's based in social psychology, which we'll talk about more in upcoming slides. And the health belief model attempts to explain and predict behavior. Its use and purpose revolves around these factors. And finally, it focuses on attitudes and beliefs. And this kind of goes back to the fact that the theory looks at the individual. Each individual's attitudes and beliefs will affect their health behavior. Okay, so now for some of the history of the health belief model. It was developed in the 1950s by U.S. Public Health Service social psychologists Godfrey Hochbaum, Erwin Rosenstock, and Stephen Kegels. These social psychologists were offering free X-ray tuberculosis screenings. The setup was mobile and they went right into people's neighborhoods so that it was more convenient for them to get screened. However, very few people took advantage of this screening. The social psychologists were left kind of scratching their heads and wondering why, so Hochbaum began research on the subject. He began looking at what encourages or discourages people from participating in new programs. He was looking at motivation and what motivates people to get tested or screened. He realized that people's beliefs about whether or not they were susceptible to disease and their perceptions of the benefits of trying to avoid disease influenced their readiness to act. This put the health belief model on track to where it is today. So the foundation of the model is the assumption of three things, or three criteria. First, that there is a threat posed by a health problem and that there are consequences. Second, that there's a way to avoid these negative consequences that is beneficial. And finally, that the individual believes that it's possible and that they're able to do what's necessary to make the change. Here are the constructs of the theory. Perceived susceptibility, perceived severity, perceived benefits, perceived barriers, modifying factors, cues to action, and self-efficacy. Modifying factors is not a true construct. Some versions of the theory include it as if it were one, and other versions leave it out altogether. We'll discuss it more later, but I put a star next to it so it's easy to remember that it's different, kind of an odd man out. These constructs address the 3 points of the foundation that we just discussed in the previous slide. It's also important to note that the health belief model can be used to either stop a current bad behavior like smoking or to add a good behavior like exercise. It's just something to keep in mind when learning about the constructs. Perceived susceptibility is the degree to which a person feels at risk for the health problem. Basically, the more someone thinks they're at risk, the greater likelihood they will be to change their behavior. Of all constructs, this is the least powerful predictor of change. Some ways to increase perception of susceptibility include informing and educating your audience, like giving them statistics, information about how exactly they are susceptible, and you could perform a risk assessment as well. It's also important to personalize the risk. So to look at this from a real-world angle and continue this example through the constructs, we'll say that we're addressing young adults who are at risk for diabetes, and we want them to begin exercising. We can give them information about what it is that puts them at risk, like high blood glucose and poor diet. We can do risk assessments to determine that they are at risk. And we can make sure to show them statistics that it's personal to them and not statistics that discuss things like maybe elderly people's risk for diabetes, because that won't help them see their own selves as being susceptible. And then there's perceived severity. This is the degree to which a person believes the consequences of the health problem will be severe. They can't think that getting the health problem is no big deal. This is often based off of medical information, like what exactly were to happen if you were to get diabetes, but it can also stem from personal beliefs about the difficulties it would cause the individual. Informing and educating works well to increase perception of severity. Again, here medical information and statistics can be used, and consequences of the health issue should be discussed, like the probabilities of disablement and survival. Looking at our diabetes example, we could give them information about how uncontrolled diabetes can lead to loss of eyesight, amputated feet or legs, and even death. The combination of perceived susceptibility and perceived severity creates the individual's perceived threat of the health problem. Perceived benefits are the positive outcomes a person believes will result from the action. This is the value or usefulness that the individual sees in adopting the new behavior. The benefits can be something as straightforward as preventing the disease. It can also be something like increased self-esteem, looks, or other things that could be benefits to an individual. In order to increase perceived benefits, it's important to give positive messages, explain the positive outcomes that can be gained from making a change. And with this construct as well, medical information can be given. We can tell our audience that if they begin exercising, they will lose weight, they'll have decreased stress, they'll save money on healthcare in the future, and that they'll reduce their blood glucose. These are all benefits that they could gain from beginning to exercise to reduce their risk of diabetes. They're all positive outcomes or benefits of taking on the new behavior. Perceived barriers is the negative outcomes a person believes will result from the action. This is an individual's own evaluation of what will get in his or her way. The obstacles that they feel they have when they're stopping an old behavior or adopting a new behavior. These barriers can be either physical or psychological. Our audience may have barriers like no time to exercise, no place to exercise, they don't like it, they don't have a membership to a gym, things like that. We want to decrease their perceived barriers. And in this example, we can give them support, assistance, reassurance, and help them plan ways to work around their barriers. We can think of ways to make exercise fun. We can help them plot out parks or other places that they can exercise. And we can set up an exercise group that meets together and things like that. Perceived barriers is the most important predictor of behavior. Change is hard for people, and barriers are most likely to keep them from changing. So it's important to spend time on this construct and help your audience get past these barriers whenever possible. Modifying factors are a feature that some versions of health belief model take into account and others do not. There are factors that influence the first four constructs, which were perceived susceptibility, perceived severity, perceived benefits, and perceived barriers. These modifying factors are things like demographics, education, culture, past experience, and so on. Their effects are not measurable, but the versions that feature them just kind of want to point out that they do play a role in people's attitudes and beliefs. Cues to action are external events that motivate a person to act. These include events, people, and things. They activate a person's readiness, moving them to change their behavior, their health behavior specifically. Some examples of cues to action include sticky notes, meeting a person with a negative health issue, or hearing alerts in the media. With our example, the youth at risk for diabetes, we could have them place sticky notes around their house or other places, reminding them to exercise, and these would be put in places where they'll see them throughout the day. We could also have someone with diabetes come and speak to the group and tell them their story and how it's affected their life. Self-efficacy is a person's belief in his or her ability to do a specific action. Self-efficacy is different than self-esteem. For example, I may have high self-esteem in general, but if someone were to come to me and ask me to be a stunt double in a movie, I wouldn't do it because I have low self-efficacy in this area. I don't know how to do it, and so I wouldn't try it. People don't like to try things that they don't think that they're capable of doing, or even if they think it'd be difficult to do. Self-efficacy can be increased through things like training, support, observing peers doing the action. So if someone were to train me how to be a stunt double, I would be much more likely to do it than if someone were to just throw me into that situation as is today. So with our target audience, again, the youth at risk for diabetes, they may not want to start exercising because they have low self-efficacy. They don't know how to exercise effectively, or they think that it'll be hard. They're out of shape and they don't think that they can do it. So what we can do is provide them with some training. We can hold workout sessions for them to learn what exercises are beneficial and how exactly to do them. And we can also provide a fitness plan that gradually increases the amount of exercise they do, so that they aren't trying to jump right into running 5 miles, but maybe they'll start out walking and ease their way into exercise, and this will kind of teach them how to ease their way in. One very important factor with the health belief model is to know your audience. You must do research to determine what is important for them. For example, we determined for this example, that losing weight is a benefit to our audience. However, this is just an example and we didn't do any real research. If we implemented this program, it might fail because this is not tailored to what's actually important to our audience. It's possible that losing weight is not something that they want and that we're promoting it as a benefit. This would discourage them from changing their behavior because it's not a benefit to them. We need to know what the real benefits are to them, what severity is to them, what their actual barriers are, and so on. So if we were to do research and gather information about what things are actually important to them, we can implement these factors into the model to make it a successful plan. Okay, so here's a diagram of the health belief model. In the first column, you can see the red arrow at the top, and it says perceptions and modifying factors. So this version does include modifying factors, which you can see in the blue box that says demographic variables, sociological variables, that kind of thing. And then you can follow all the little orange arrows to see at which point each construct influences each other. And this follows all the way to the likelihood of preventive action, which would be the likelihood of the change that you want to be made. Okay, so here's an example of a health belief model-based health behavior change plan. I made it for myself, and my plan was to start doing yoga 5 days per week for 30 minutes each day. What I did was look at each construct of the health belief model, which you can see in the far left column. And I determined an activity that I could do to tackle each construct. And this is just an example of the constructs in use with another behavior. I'll give you a minute to look it over. I don't want to read it all to you. Okay, the applications and uses of the health belief model are very broad. Because health motivation is central to the focus of this theory, the obvious uses in addressing health behaviors. It's applicable to most any health behavior in any subject population. It's commonly used in public health for interventions in areas like HIV, seatbelt use, diabetes prevention, like in the example in this presentation, health screenings, and many more examples. It can also be used in a clinical setting to help promote adherence to medication and treatment schedules, and it's useful in both short and long-term programs. Some critiques or limitations of the health belief model are that it does not address social and environmental factors, which is unrealistic because these factors have an impact on our attitudes and beliefs. This may be why some of the versions feature modifying factors. They just kind of want to note that it's known that outside forces play a role in individual decision making, but this isn't really a measurable factor in the health belief model. This model also assumes that everyone has equal access to information and equal levels of information. It's always true that some people have more information, other people have less information about certain topics, but the very nature of this theory involves educating and informing. So if you were to make a plan that revolved around the health belief model, and that gap would close between your participants because you'd be giving them information. And a final limitation is that beliefs and attitudes of an individual change over time. Again, this is true, but we try to look at their belief at the time of the intervention or program that's based on the health belief model and work from there. Okay, now I want to share with you a study that uses the health belief model to plan its intervention. So again, this is just another example. The title of the article is Closing the Gap on Mammogram Screening, an experimental intervention among low-income Hispanic women in community health clinics. The purpose of this study was to examine whether targeted cancer prevention education based on the health belief model influenced mammogram screening beliefs and increased intentions of low-income Hispanic women to obtain mammograms. The intervention was a post-test only control group experiment. The participants were randomized into two groups, an intervention group and a control group. The intervention group viewed a mammogram video and received a brochure and a handout based on the health belief model constructs. The information in the materials included an explanation of a mammogram screening, definitions of mammogram guidelines, and corrections of false rumors about breast cancer and mammogram screenings and things like that. The information was all grouped so that it followed the health belief model constructs. And the control group had no education. Both groups took a post-test assessing health beliefs and mammogram intentions. The results of the study concluded that the intervention was successful in changing the health beliefs and increasing the intentions of obtaining a mammogram in the intervention group when compared to the control group. The limitations of the study include that the study did not measure behavior, so increased mammogram screening intention doesn't mean that these women were actually getting the screenings. There's also a possibility of cross-contamination because the women in the study were all went to one of two clinics, and so they could have seen each other at the clinic, spoken to each other, that kind of thing. And also, different forms of communication, rather than just the video and the brochures, could have been beneficial, like maybe adding a class discussion so they could bring up things about their concerns, maybe like their barriers, and discuss those kind of things in a classroom setting. I hope you enjoyed learning about the health belief model, and here are my references.